So second thing is the neurogenic response. What is a neurogenic response? So this involves the control of small and medium-sized vessel diameters, little bit a small higher size, right? Neurons and other cell types like astrocytes, microglia secrete a variety of neurotransmitters with vasoactive properties. Okay, for instance, you can take this acetylcholine and nitric oxide. They are all vasodilators, while serotonin and neuropeptide Y are vasoconstrictors, right? So astrocytes, neurons and other microglial cells, they are bound to secrete this kind of either vasodilator or vasoconstrictor depending upon the local metabolic demand at that particular environment. Okay, these are not systemic things. These are not systemic things. In particular area of the brain, if there is a demand is very high in a particular cells, in a particular segment of cells, then the astrocytes, microglia or neurons very near to that particular environment will start secreting this kind of either vasodilators or vasoconstrictors. Okay, this is called as neurogenic theory. With infrared video microscopy of interneurons, which is a latest technology, okay, they have viewed this interneurons and adjacent microvessels. Okay, they have viewed the neurons and they have seen the vessels, okay, in rodents. And Call et al. Showed that increased depolarization activity of single cortical interneuron results in precise vasomotor response in the neighboring microvessels. Okay, you stimulate this particular neuron, this particular vessel has conferred either dilatation or constriction. Okay, this proves that this neuron is responsible for this dilatation or constriction of the nearby microvessels, okay, through some neurotransmitters. So Call et al. Has actually confirmed that neurons can vasodilate or vasoconstrict by means of some vasodilators or vasoconstrictors by neurotransmitters. Okay, not only that, further he showed that directly if you apply this particular neurotransmitters, that will be a vasodilator, directly if you apply over the perivascular area, similar reaction happens in that vessels. Okay, you apply nitric oxide, you applied acetylcholine, or you apply serotonin, the same vasodilatory or constriction is happening at that point. Okay, so he did two things. One, through the infrared video microscopy, he has studied the neurons and the microvessels. He has stimulated the neuron and saw that that particular area's microvessels is going for dilatation or constriction. Number one. Second, he took some vasodilators or vasoconstrictors and he has applied it directly over that particular vessel, which shows sensitivity to this kind of vasopressors or vasodilators, right? It's not that all the vessels should show some vasodilatory properties or vasoconstrictive properties. Okay, they show vasodilation or vasoconstriction only if they are receptive. Okay, so both of it was proved by Call et al. So on a large scale, how are we using this? This kind of neurogenic theory is that these changes in the blood flow in response to the neural activation are observed in the BOLD, that's called as a blood oxygen level dependent signals. Okay, this is used for functional magnetic resonance imaging. Okay, for example, in a particular area, if the oxygen demand is very high, for example, you are deeply thinking about certain things, the oxygen demand in that particular area is going to be very high, right? So in that area, the neurons actually secrete neurotransmitters causing vasodilatation. This is being used in functional MRI. Got it? This is being used in functional MRI. So the BOLD response has been adapted in many fMRI studies investigating increased cerebral metabolic demand in cognitive tasks, spatial memory, visual processing, and various disease states. Okay, so basically there will be local metabolites as well, but neurons itself will sense that this particular brain material is hyper functioning. Okay, so neurons themselves can sense that this particular material is hyper working because of the oxygen levels in that. Okay, so they start producing this vasodilator or vasoconstrictors. So now, very important question I'll ask you. Okay, so imagine there is a hypertensive emergency, BP has shot up to 240 or 250. Okay, and the patient is coming with the seizures, and you do an MRI. The report comes as PRES, P-R-E-S, posterior reversible encephalopathy syndrome, right? So why it is called as posterior? Why it can't be anterior, ARES? Or why it can't be brainstem, BRES? Why only PRES is hit? Posterior reversible encephalopathy syndrome. There is no ARES, right? There is no anterior reversible encephalopathy syndrome, or there is no brainstem reversible encephalopathy syndrome, right? Why only posterior? So when there is an hypertension, only the posterior circulation is affected more than the anterior circulation, than the brainstem, right? Any particular reason behind it? That is because of the regional heterogeneity. Okay, so the anterior, for example, you have a pipeline and there is a lot of blood going to come through it, and at one point there are a lot of branches. Imagine there are a lot of branches to this vessel, and through the branches there is an end organ. So this end organ may not get affected because pressure is distributed across this kind of branches. But imagine there is a pipe and a lot of blood is coming and the end organ is directly over it. So this organ will get affected because there is no much of a branches to this particular vessel. Okay, or there is a vessel, there is an end organ. Okay, if there is good mechanism to stop it, if there is a good mechanism to control it, then also this end organ will not suffer. This is the basics, right? So anterior circulatory system of the brain possesses a denser sympathetic innervation than that of the posterior system. Okay, when there is denser sympathetic innervations, it means the neurons can act immediately. Right? Once the neuron act immediately, they will dilate the vessels. They will dilate all the collateral vessels as such, right? Decreasing the pressure, right? So when they decrease the pressure, the end organ, the end lobe, maybe the frontal lobe or the parietal lobe will not get affected. Okay. So the anterior circulation is controlled mainly by adrenergic sympathetic relays from the superior cervical ganglion as they travel up the carotid arteries. Okay. So they have a good sympathetic innervation in the anterior circulation. So even if the blood pressure increases, the neuron systems will take care of it. Okay, they will secrete vasodilators, decreasing the pressure towards that particular end organ, right? Similarly, there is autoregulatory mechanism which is very effective in the brainstem as well, right? So brainstem is also preserved, anterior circulation is also preserved, but the posterior vessels instead depend on the sympathetic chain via the vertebrobasilar arteries, which is very weak compared to the anterior circulation, right? So there is no big sympathetic chain in the posterior circulation which can support the brain material when the BP shoots up, right? So when the BP shoots up, anterior circulation is saved because there is significant sympathetic innervation. Brainstem is saved because there is significant autoregulation. But in the posterior circulation, there is no enough sympathetic chain, there is no enough autoregulatory mechanism. The posterior circulation, the posterior brain goes for vasogenic edema. Okay, and it is not only posterior circulation because every human brain is not the same. Right? If you do a cerebral angio for some 1,000 people, you don't get the same report anatomically itself. I'm saying anatomically, some vessel may be missing by birth, right? Some collaterals may be added or newly found in some individuals, right? So if at all the autoregulatory mechanism is poor, if at all the sympathetic innervation is poor, that part of the brain will go for vasogenic edema. Okay, we have seen vasogenic edema even in the brainstem areas. Okay, this is called as a atypical press. So next time when someone asks you why the posterior reversible encephalopathy syndrome, when the BP is very high, only the posterior circulation is affected, your answer should be in the anterior circulation there is dense sympathetic innervation which can prevent the brain, which can preserve the brain from this kind of high output states. Similar things happens in the brainstem, but the sympathetic innervation, the posterior circulation is extremely weak. So when the BP rises very high, the patient can have a vasogenic edema. So need not be extremely posterior and need not be reversible always. Okay. So why posterior? In severe hypertension in anesthetist cats, cerebral blood flow significantly increases in the anterior circulation, whereas the brainstem had only modest increase in inflow. Okay. So in brainstem, autoregulatory mechanism will take care. In anterior circulation, apart from autoregulatory mechanism, there are collaterals also getting opened up, right? So this regional variability may play a key role in developing posterior reversible encephalopathy syndrome because both these mechanisms are not there or very compromised in the posterior circulation. So PRESS, the posterior reversible encephalopathy syndrome, which is not always posterior and may not be always reversible, okay, is characterized radiologically by transient bilateral subcortical vasogenic edema in the posterior circulation. Okay, so explanation for the edema's apparent posterior predilection is relative breadth of the sympathetic tone in that particular area, leading to poor autoregulation during the hypertensive episodes. Okay, self-explanatory. Coming to the third, okay, you saw the myogenic theory, you saw the neurogenic theory. Myogenic theory, you know what is cadasal, and neurogenic theory, you know what happened in the PRES, and now coming to the metabolic mechanism. Okay, this occurs in the small vessels, subject to changes in the local environmental issues. Most notably, carbon dioxide alters the vasomotor response. Every 1 mm increase in the PCO2 corresponds to roughly 4% increase in cerebral blood flow. Okay, so do you remember in my first few slides I told you systemic carbon dioxide is different, that is one phenomena, but localized in a particular area of the brain, if the blood supply is not adequate, that particular area of the brain suffers ischemic insults. It goes for anaerobic respiration. Because of anaerobic respiration, O2 goes down, CO2 goes high, and the sugars also goes down, right? So this kind of increase in carbon dioxide, for example, there is a vessel, okay, there is a blood vessel. Take this as maybe M2, okay, some branch M2. So there is an infarct here. So this particular brain material here will have increased PCO2, decreased O2, and decreased sugars, CBG, okay, sugar, blood sugar. Okay, so this localized environmental issues can alter the diameter of the particular vessel. Okay, for example, 1 mm Hg increase in PaCO2 corresponds to roughly 4% increase in the cerebral blood flow. So CO2 accumulate and cause vasodilatation. So hypotension below the lower autoregulatory limit results in tissue hyperperfusion and thus the anaerobic respiration. Okay, similarly, this is in hypoperfusion. In hyperperfusion, there is more washout, there is decrease in PaCO2 and vasoconstriction occurs. Okay, this happens both in systemic way or if it's a localized way. Okay, PaCO2 is the entire body, right? Even in systemic CO2 goes high or goes down, this kind of alterations can occur, or segmentalized a particular tissue of the brain if it suffers from increased CO2 or decreased CO2, also this kind of vasoconstriction, vasodilatation may occur. Okay, so this vasomotor response is regulated by proton concentration in the smooth muscle cells of cerebral vessels. Whenever you say about the proton concentration, you are speaking about carbonic anhydrase. Okay, speaking about carbonic anhydrase and pH, right? So proton gradients are regulated by carbonic anhydrase activity, which depends upon the pH. Okay, prolonged hypocapnia. Hypocapnia means alkalosis, right? So it generates tissue alkalosis. In alkalosis, there will be increased carbonic anhydrase activity. Okay, so maybe by this mechanism also, the CO2 can cause alteration in the vasculature. Okay, so increase in CO2 increases the pressure by increasing the diameter. Decreasing the CO2 decreases the diameter, decreases the blood flow. Okay, so this is about the CO2, maybe systemic or localized to that particular tissue. Additionally, decreased oxygen partial pressures can increase the cerebral blood flow. This is also systemic and segmentalized, right? However, the hypoxia has to be very severe, like less than 50 mm Hg. Okay, systemically itself, if there is hypoxia, the similar situation occurs. Okay, there will be transient cerebral vasculature dilatation if there is a low oxygen. Similarly, if any particular segment of the brain is infarcted and it is low in oxygen tension, then also it supplies some metabolic areas. It will address there is a low O2 at that particular area. So nearby vasculature will go for dilatation. Okay, that's the second mechanism. And third, the hypoglycemia. Severe hypoglycemia at levels less than 2 millimoles per liter can lead to increase in cerebral blood flow. Okay, these are all basic nutrients: sugar, O2, and increasing CO2. Right. Coming to the endothelial mechanism. Endothelial secretes vasodilators like nitric oxide, which we already know, and vasoconstrictors like thromboxane A2 and endothelin 1 in paracrine manner. Okay, two only nearby tissues, nearby areas. But why this is brought here in this discussion is, we do give statins for all the infarcts, whether it's heart, whether it's a brain, we do give statins, right? Understand, statins do regulate this autoregulation. Okay, for many of you, this could be a new information. Statins can upregulate nitric oxide synthase. Okay, when there is nitric oxide, the vessel go for dilatation, better blood flow, right? Statins can upregulate nitric oxide synthase, causing cerebral artery dilatation and increase cerebral blood flow. So you don't give statins in bleed patients, right? In ICH you don't give, but in infarct you give, right? So how does statins upregulate the nitric oxide synthase, right? So this mechanism occurs by inhibiting the small G proteins known as the RAA and RAC. Okay, RAA, what it does is negatively regulates the endothelial nitric oxide synthase. They basically decrease the nitric oxide synthase. Okay, statins will inhibit the RAA, thereby nitric oxide synthase increases and more production of nitric oxide happens, so vasodilatation happens. Okay, so RAA negatively regulates endothelial nitric oxide synthase. Statins inhibit the RAA GTPase activity via inhibition of the process known as granulation, a type of fibrillation that ultimately converts nitric oxide synthase upregulation. Okay, you just remember the statins decreases the activity of RAA, thereby increasing the activity of nitric oxide synthase. So this is called as cerebral autoregulation. You need to have an idea about what carbon dioxide does, systemic carbon dioxide does. You need to have an idea about what is flow metabolism demand. You need to have an idea about pressure related autoregulation demands. Okay, so this pressure related autoregulation has 4 mechanisms, right? The neurogenic, the myogenic, the endothelial, and the metabolic, right? So now, how will you measure this autoregulation? If you ask me a question, so what is the blood pressure you need to maintain for this particular patient? The patient may be an ICH patient, the patient may be an ischemic patient, the patient may be a just neurologically operated patient of the brain for some tumor, or the patient can have a significant cerebral edema for any cause, metabolic reasons. If you ask me what is the blood pressure target, some guidelines will give you a number. Okay, 160 or 180 or 220 or less than 140. There are various numbers. So how did they derive at that number? How does one number fit for all? One size never fits all, right? So how does one number fit all patients? Okay, ideally, no one size can fit all. No single number can fit all. These are only guidelines. They are not like rules to be followed. They are only guidelines. Ultimately, if possible, you need to measure the CCP. Okay, you need to measure the MAP, you need to measure the CPP, you need to put an electrode into the brain, and you need to calculate the CPP and target the CPP properly, right? Otherwise, you need to know whether the autoregulatory function is better. You need to document that from this blood pressure to this blood pressure, there is a good autoregulatory function for my patient. So you need to titrate your blood pressure within this channel, within this range, right? So that is where we are heading towards. If at all by some technology, we are able to identify or we are able to measure the autoregulation, then we can plot it up in a paper from this blood pressure to this blood pressure is safe for the patient. We can titrate our drugs accordingly, right? So autoregulation is accessible by examining the changes in the cerebral blood flow or its surrogates and response with the cerebral perfusion pressure or its surrogates. Okay, so what is the blood flow? Systemic blood flow or the MAP or the surrogates, and what happens in the brain, the perfusion pressure. So methods to measure cerebral autoregulation. Okay, some of us used this kind of transcranial Doppler ultrasound. Other things are on the research basis. Yes, this is all used in the systems. They have a lot of complicated algorithm to function. So just know the names. If you write this in your exam, you'll get additional marks. Okay, need not explain individually, right? So methods to measure cerebral autoregulation: transcranial Doppler ultrasound, transfer function analysis, time domain analysis, wavelet analysis, projection pursuit regression. Okay, these are some of the methods to measure cerebral autoregulation. Okay, so ideally, what is the plan? What is the idea to measure? So this is the brain, right? So first, you are going to see what is the blood flow in the brain when the systolic BP is somewhere like 100. And then you're going to increase the blood pressure maybe to 180, and you're going to check what is the cerebral blood flow. Or maybe you can increase the blood pressure to 200 and check what happens to the cerebral blood flow, right? So these are called a static analysis. Okay, one blood pressure at a time, and you're going to monitor how is the blood flow in the brain. For 100 pressure, what is the blood flow? For 180 pressure, what is the blood flow? For 200 pressure, what is the blood flow? This is called static analysis. Or the other way around is dynamic analysis. From 100, you can gradually go to 180. Thereby, you can monitor the velocity or the flow of the blood in the cerebral vasculature in a real-time basis by using a transcranial Doppler, right? These are all dynamic parameters, okay, dynamic way to assess. So how does it work? The measuring system, how does it work? So first thing is you need to induce the blood pressure changes and check for autoregulation, right? How will blood pressure go from 100 to 180? There are a lot of ways to increase the blood pressure from 100 to 180, right? You can tilt the patient down. You can start the patient on adrenaline or noradrenaline. You can just give a bolus, or you can tie the large volume BP cuff in bilateral thighs of the patient, right? That can increase the blood pressure to around 30 or 25 mmHg. When you relax it, there will be a BP fall of 25 to 30 mm of Hg. So all these things can happen, okay? Either physically or pharmacologically, you can increase the blood pressure of the patient. You can assess the cerebral blood flow. That is one way. But will you do this in your patient who is having an ICP, in your patient who is having an SAH? Will you artificially increase the blood pressure to 180 or 200? Will you check like that? Idea is no. The answer is no, right? In ICU patients, we don't do that, right? So this kind of inducing the blood pressure and checking may not be safe for the ICU patients. So other way around, what you can do is you can choose an isolated blood vessel, maybe a temporal vessel or something. You can use isolated intracranial vessels without any particular blood pressure challenges. You're not going to include any challenge protocols. You're not going to inject any boluses. You're not going to suddenly increase the blood pressure, right? There is no challenge protocols there. Okay, you're going to check the blood pressure whenever there is fluctuations. Okay, in your ICU, for every patient, there are going to be some blood pressure changes. Maybe during the NORAD changing, maybe the tube changing, maybe during the syringe filling phase, or when the patient is trying to cough, when the patient is trying to wake up, when you stop the sedation, when you restart the sedation, deep down into the sleep, all these times, there will be some fluctuations in blood pressure, right? You will not see a patient with 120/80 always, right? During a deep sleep or out of sedation or onto sedation while bowel opening, there are a lot of reasons why the blood pressure fluctuates in not naturally itself. You don't induce it, right? So you don't induce it. There will be some other fluctuations because of other common reasons in ICU. During that time, go and assess the autoregulation. Go and assess that particular vessel in the brain, maybe by a transcranial Doppler. Okay, you'll be able to find whether the flow is increased or flow is decreased. Okay, so this approach renders dynamic assessment of cerebral autoregulation safe and feasible for patients with acute brain injury, right? So now I'll give you a scenario. Just imagine if you take a deep breath, your BP will fluctuate, right? On regular breath itself, BP will fluctuate. Will your brain vasculature react to this kind of every breath situation? Answer is no, right? So if at all, the change in the blood pressure is very fast. Like you breathe, right? You breathe a day in and day out, you breathe. The patient breathes. Possibly every 5 seconds, the patient breathes, right? So this kind of fast changes will be filtered. Okay, so the dynamic response is likely to occur within 10 to 15 seconds. Okay, arterioles can counter slow fluctuations in systolic BP. Okay, faster changes such as those greater than 0.5 Hz are not compensated. For example, those occurring with each cardiac cycle, right? So each cardiac cycle will not be having a compensatory mechanism in the brain. Okay, for each cardiac cycle, there is no autoregulatory system, right? Imagine for every cardiac cycle, if there's an autoregulatory system in the brain, then brain also will be starting to pulsatile, right? So this kind of faster changes will not be given any compensation or any resistance in the brain. Okay, so this selective compensation is refers to as high pass filter principle. It's called high pass filter principle. The cerebrovascular system buffers against the slow hemodynamic oscillations, while the higher frequencies may pass unfiltered to the brain circulation. Higher frequencies like the cardiac systoles will just pass towards the brain, right? There is no compensation, there is no autoregulatory mechanism, that is not going to be useful here. Okay, if the frequency is very high, it just goes to the brain, right? So that the normal things will not be compensated by autoregulatory mechanism. If it's by other means, like a BP fall during a syringe change, or by tilting the patient, or changing the tube, or inducing with sedation, that kind of slow form of BP fall or BP increase, blood pressure increase, fluctuations BP, that will be seen by the autoregulatory mechanism, and that will be given for compensation. Okay, this is called as high pass filter principle. So coming to the conclusion, you know what is cerebral autoregulation? It's a pressure dependent autoregulatory mechanism in the brain, right? Somewhere from 50 to 150 of systemic blood pressure, you will be able to titrate in normal individuals, right? The cerebral blood flow will be maintained in a stable situation from systolic blood pressure of 50 to 150, right? Below 50 or more than 150, the thing is going to be compromised. But the issue is, in your patient with a cerebral trauma or neurosurgical patients or an ICH bleed or infarct, this cerebral autoregulation may not be completely normal, may be insulted, right? So you need to know what is the cerebral autoregulation range for that particular patient, right? So you need to know what is cerebral autoregulation, and you need to know whether in your patient that is working or not. If it's working, which part of the brain is working, right? So based upon that only, you can titrate and keep a set range of blood pressure for that particular person. Otherwise, you can use only guidelines, right? So how to understand what is the correct range of autoregulatory range for that particular patient? Optimal pressure is calculated by plotting the cerebral autoregulation indices against a range of blood pressure over a 4-hour monitoring period, right? Over 4 hours, you check whenever the BP is increased, whenever BP is less, you go do the translinear Doppler, you need to document the flow rates, okay? And you need to check within from what blood pressure to what blood pressure the transcranial Doppler flow is maintaining stable. Only within that range, if you can maintain the blood supply to the brain, if you within that range, if you can maintain the systemic blood pressure or the MAP, then the patient's brain is going to be more safe. Okay, so You should know what is cerebral autoregulation, and you should know what are the theories behind it, and you need to know what is cadacil, and you need to know what is PRES, and why in PRES only the posterior component is more involved than the anterior or the brainstem, and you need to know what are the genetic factors behind it, and what are the ways to measure it, okay, and in what way it's going to be helpful in the future. Okay, this is called as cerebral autoregulation. Thank you.